That's great. Well, why don't we just segue straight to Dr. Paterson then next for, I believe we were going to talk about some techniques for biceps tenodesis, which is yet another anchor that people kind of leave out when they're talking about cuffs. But I don't know about you guys, but I'm a biceps killer, and there's rarely one that survives. And so that's you plus one on basically all cuff repairs. And we studied that. I wrote up J.P. Warner's patients and found that the location didn't really matter. So suprapectoral is a great place, in my opinion, to tenodese things. And I think that's where Dr. Paterson is going to. So let's see how he does it.
Thanks for having me. Absolutely happy to be here. As I kind of mentioned earlier, I've been in practice for about 9 years and basically been a tunneler guy, Transosseous guy ever since I came out. Biceps is one of those things I've gone back and forth. I've used probably most techniques that you can imagine. Finally, eventually came up with this Transosseous technique. So I'm not really going to talk about indications, although like Brett mentioned, it's very rare that if I'm doing a cuff that the biceps doesn't get tenotomized or tenodesed. So yeah, it's a pretty common indication for me that I'm doing a tenodesis. So again, just real quick about this technique in particular, as we've mentioned, it's clearly cheaper than using anchors or an interference screw or whatever other biceps implant you're going to use. It's all arthroscopic, although I do spend a minute preparing the biceps outside the joint, as you'll see. It opens up the groove, so people talk about groove pain, whether it's from not opening the groove or putting an interference screw in there. This reduces the risk of that. You tie one single knot. I believe it's a self-reinforcing construct, and I'll kind of show a little rudimentary slide of that at the end of it. And the thing that really sold me on this is that there is some evidence that even with an interference screw technique, the healing occurs where the biceps is contacting the humerus on the outside. It's not in the socket where the actual healing occurs. So, then, why would you even put an interference screw in there? So that's kind of the rationale. These are my standard portals, posterior portal, posterolateral for rotator cuff, anterolateral, anterior portal, and then the B is the biceps portal that usually ends up being pretty much in between anterior and anterolateral. It's generally pretty much anterior with the arm at about 10 degrees of internal rotation, which puts you pretty much in line with the bicipital groove. Interarticularly, first we localize the biceps. We're going to decide we're going to do a tenodesis, and then percutaneously place a spinal needle to essentially tag and immobilize the biceps. So I tag the biceps with a spinal needle and then release it before I do the tenodesis. So the biceps is tenotomized, but it's tagged with the spinal needle. Then once I'm in the subacromial space, I'll find that spinal needle. So this is with the scope in the anterolateral portal viewing. So this tells me exactly where the biceps is. So, for some other techniques, if you're trying to find the bicipital groove once you're in the subacromial space, sometimes that's not so easy. This makes it, you don't have to think about it. So what I've always said is, the less I have to think during surgery, the better. So I don't even have to think about it. That's exactly where the biceps is. Then next I established the biceps portal. So that's done using an outside-in technique using the spinal needle. So this other second spinal needle is, I'm making sure that portal is in line with the bicipital groove. And then basically through that biceps portal, we'll open up the bicipital groove and clean it out, debride it. The other thing I really like about opening up the bicipital groove is, occasionally in that anterior bicipital groove, you'll see a little subscap split tear, and this is how I fix the subscap too. So it makes it very, very easy if there's that split tear of the subscap. You just put a tunnel there and fix that, and then you can do your biceps tenodesis on top of it. So that when I'm doing a cuff and biceps, that's how I do it. It's subscap first, biceps tenodesis, and then posterior superior cuff repair. Then the biceps is exteriorized, and I remove about the proximal centimeter or so, and just do a quick whip stitch with whatever suture of choice, high tensile strength suture you want to use. I typically don't use tape. I'm sure you could. I just have used suture. So prepare the biceps and then put it back in the joint and bring the sutures out through the posterior portal. And then I'll prepare the bone. I'm a big believer in preparing the bone. I really, whether this is true or not, I was very intrigued to hear that there's research that shows you can leave Sharpie fibers on the greater tuberosity. So maybe that's going to change my philosophy about that a little bit. But I've been a very aggressive bone preparer. I really think you need to get it down to bleeding, bone marrow elements. So this is what it looks like after I've prepared it. So, I want to put the biceps on there and have something for it to heal to. So punch the first tunnel at the superior aspect of the bicipital groove. And then it's kind of hard to see, but here's the transos, the medial hook of the transos, and then the lateral, that's where the lateral punch goes. So the tunnel is in the bicipital groove, in line with the bicipital groove. So you have the loop coming out medially, the two other sutures coming out laterally. And then we'll grab the sutures that are tagging the biceps through that loop. So the suture grabber goes through the loop, grab the sutures, pull them through, and then you use the lateral limbs of the shuttling suture to shuttle the biceps sutures through the tunnel. And then this picture, so this is this is a right shoulder, that was a left shoulder. So these are the sutures coming out through the biceps. That's the medial tunnel, out laterally. Then I'll grab one around each side of the biceps and tie it down. So there's 2 points of fixation. There's a point where the biceps is attached medially at the medial tunnel, and then it's cerclaged around the biceps laterally. So it probably attaches about 1.5 to 2 centimeters of the biceps, like onlay technique, onto the proximal humerus. So this is kind of what it looks like at the end. That's the lateral tunnel, and then the biceps is fixed medially, and same thing. Another video, I think it provides pretty stable fixation and kind of compression of that proximal, that good centimeter and a half of the biceps onto the bone. And I like the idea that it's out of the cuff repair. I'm a little iffy about, repairing or tenodecing the biceps kind of in the rotator cuff repair. I'm not sure I want stuff in between the rotator cuff and the tuberosity. So I know some really smart people do it that way. I'm just not sure that's for me. So this was my amazing drawing of, that with this technique, if you're contracting the biceps and you're getting kind of that downward contraction of the biceps, what's going to happen is it's going to pull on these sutures, which is going to tighten that cerclage suture. So that's why I call it a self-reinforcing technique. Whether that's actually true or not, I haven't done a research study on it, but I mean, it's almost like a little finger trap. If you pull on it, it's going to make it tighter. So then I guess the argument would be like, does that lead to failure? And, although I've been doing this technique for a couple of years, so, I mean, I don't know how many I've done, a few hundred of them. And, I'm sure I've had failures, but I have not revised one. So if it fails, people either don't notice it, or maybe it just fails, maybe it pulls a little and it heals. When I used to use interference screws and other various techniques, I was revising a couple of them a year. I have not yet revised one of these, so that's my take on it. Interested to hear what anyone else has to say about it. Maybe they think I'm crazy doing it this way, but appreciate the opportunity.
Great talk. Um, I didn't even think about doing the tenodesis that way, but I like the idea of it. I've incorporated. I do it two ways. I incorporate it into the cuff repair, and I do it where I'm passing my tunnel through the groove, but out laterally through the greater tuberosity. And I kind of leave the biceps in situ. Sometimes I still leave it attached to the labrum, and those are usually cases where there's biceps instability. And I'll secure the biceps into the groove, hold it there. It'll tenodese there, but that might be a patient who needs maybe a little SCR type help with the biceps. There might be some advantages. If they have a slap tear, I don't leave it attached, but it does give me that option, I suppose. But I like that technique, and I like staying within the groove there. So great talk, great technique.
Thank you. Yeah, that's the other thing is the whole using the biceps as your kind of SCR. So that's, you know, not related to this particular technique, but something that can easily be done using the transosseous technique as well.
Yeah, I'll keep it attached, and a lot of times we'll whip stitch it in the anterior tunnel adjacent to the cuff tear. Do a Mason Allen suture on it, cerclage type suture, and often if there's a subscap tear, I'll tunnel and keep it inside you and spear it on purpose. You know, tunnel through it simultaneously, tenodesing the biceps and repairing the subscap at the same time, just for time. I tend to use the horizontally oriented tunnels, but I could see how I've done your technique a couple times where I just wanted to save time and just have two fixation points for one there by vertically orienting. So I have used that a few times to save time. So you taught me that. Cool. Uma, how do you do it? Are you still with us?
Yeah, I'm here. That was great talk, Bill. That's an interesting technique. I think you're right. It is a self-reinforcing, and I think that's true for the cuff tunnels as well. I mean, it's essentially almost like a tension band type technique. So if you're tying your knots in a little bit of abduction, when they bring their arm down, it should reinforce that repair, you know, to get tighter. So I think that's a nice way of doing it. But I'll typically, if I'm doing it high, I actually prefer sub pec. So I'm just completely out of the group here completely. But this, if I have to do it high, if there's an enchondroma or something I'm trying to avoid, I'll just usually bring it in just into the high groove or next to the anterior part of the repair. Like you, Brett.
Yeah, I've actually done a couple of biceps, LHB biceps autographed SCRs using a tunnel, cerclaging the biceps, tenodesing it suprapectorally, then incising it, swinging it over. And when you have that bicep, you have that biceps control suture that you can pass through a tunnel. With the 2-point fixation of a tunnel, you can actually secure that quite nicely. I've got some video of that I might be able to find here. But let me see if I can go ahead and show first what I was planning on doing here.